Hi, I'm Fernando Agreda, urologist working in Barcelona and Panama. I've developed a HoLEP technique called Sphincter first HoLEP. The basis of the Sphincter first HoLEP were published in the Journal of Endourology in June 2023, and the DOE will be provided in the video description. Thanks for watching and sharing this video. The first step is always, as we can see I'm trying to do here, is to locate the mucosa covering the external sphincteric mucosa, and you can see here I already localized it, and now I'm trying to start the dissection of the sphincter and sphincteric mucosa. So the first step is to cut through the urethral mucosa, as I'm doing here, in a very progressive manner. Has to be very progressive. You have to cut first through the urethral epithelium, then through the urethral fibers. You have to keep always the laser beam in an approximately 45 angle direction. You should be pointing towards the anterior prostatic capsule, which of course you cannot see here, but you know that is located there. You have to keep this direction of dissection without using any blunt dissection in this particular first step. I'm only using the energy of the laser. I have to say that I'm using a very low power energy here. I'm using 30 joules and 1 hertz, so it will be 30 watts. So I just needed to cut very progressive through the urethral epithelium, through the urethral fibers, and through a section of adenoma, because it's impossible to go straight in this plane without leaving some adenoma in the dorsal, in the anterior aspect of the prostate, anterior distal aspect of the prostate. I'm doing that same movement here, and I'm going from 3 o'clock to 9 o'clock, very progressive, very slow, till I get some circular fibers, which means I'm in the prostatic capsule, anterior prostatic capsule. Here I'm still progressing in that direction. You can see already some semicircular fibers there. Here I'm getting to this dissection plane. There's no rush. You have to do it very carefully to avoid any stretching or heat damage of the sphincteric external sphincter muscle. So you can see here. Now that's it. You can see there's some semicircular fibers. I'm separating this last portion of adenoma here, and you can see very clearly there. I will point it here, so you can see I pointed there, and now I'm completing this dissection through the left part of the prostate of this patient. So you can see there's no lesion of the sphincteric mucosa, and now after we progress and we actually complete the liberation of the sphincteric mucosa in the anterior aspect, we go to dissect the left lobe. It's very easy now. Now we are very completely sure that the sphincteric mucosa and main part of the sphincteric external sphincter is free from tension from our dissection or from any kind of damage that we can produce by stretching or depithelialization. So we can progress. As you can see here, you have to connect that dissection we did there on the first part of the surgery with the lateral and I would say posterior aspect of the left adenoma here, as we progress towards the first plane of dissection. We have to make these two planes to do a complete correct plane of dissection. That's it. That's the first step. So the most difficult part of this SF HoLEP, I would say, is to go to the first dissection of the anterior part of the sphincteric mucosa and to locate the anterior prostatic capsule, because there are no references in there. There is no capsule you can see, there's no urethra you can see, there's no bladder you can see, so you have to be very careful and trust the process. So you can see here I'm using the laser beam to almost white any kind of attachment of the adenoma to the prostate capsule in a very progressive, very slow, I wouldn't say slow, I would say controlled. There's almost no bleeding there because I'm using the laser as it's supposed to be used. Almost no, or I wouldn't say no blunt dissection, but it will be kind of nonsense. But the only use of the scope is to locate the plane. Here I start with the dissection of the right lobe, same process. I mark the distal aspect of the right lobe and then I do a mucosal incision in the direction of the previously done sphincteric dissection here. Now it's all connected only in mucosa first, and then you have to deepen this dissection till you get to the capsule and the adenoma. As you can see here, it's very clear actually. It's very schematic, and you can try it in your own practice. With this kind of dissection, as you can see in the published data, I have achieved very nice, I would say very competitive, very good numbers in immediate continence and 1 month and 6 months rate of continence. Here you can see how the laser is applied to the interface between the adenoma and the capsule, and there's almost no bleeding here. This patient got a prostatic artery embolization 6 months ago. He didn't improve very much in his LUTs, even when the prostate was reduced a little bit and the PSA also, but his feelings, his symptoms didn't improve that much as the volume estimated by the transabdominal echography and by PSA was reduced. So we decided to go with a let's say traditional kind of surgery, which in our institution is the hormone laser enucleation of the prostate, and in this case, if I'm performing the surgery, I will go with my own sphincter first HoLEP. So as you can see here, we complete the plane of the section. We have a complete semicircular plane starting from the around 7 hours to the 5 hours and the distal aspect of the adenoma. So now we only have to continue this plane till we get to the bladder. In the sphincter first HoLEP, the last part of the dissection goes through the verumontanum. We usually go anterior first to dissect the sphincteric mucosa and the external sphincter, and then we dissect both lateral lobes, and we progress anteriorly till we get to the bladder. I will show you here. This is the only part, and this is the sphincteric mucosa completely intact. So in this first 7 to 8 minutes, we have released the sphincteric mucosa and external sphincter for any kind of obstruction that we could make with our dissection, with our progression of the dissection of the adenoma. Now we continue the progress of the enucleation always through the anterior aspect of the capsule and the anterior aspect of the adenoma. We do a semicircular dissection from 3 o'clock to 9 o'clock and vice versa till we reach the bladder neck fibers and the bladder, so we have that reference, and then we progress to do the I will say the bladder neck dissection, and then the last part is to do the verumontanum anterograde dissection and to free the adenoma as a whole block. It's kind of a block enucleation with a different progress of dissection. So we liberate finally the adenoma to the bladder to do the morcellation. So as you can see here, I don't know if you see it, there's some blue spot in the right prostatic capsule that probably some embolization material. So as you can see there, that's what's it. Some blue material used for the embolization. I've done some HoLEP after embolization, and I've seen that material in some, I will say, arteries. They should supposed to be arteries in the adenoma and in the capsule when I'm performing the enucleation. So I'm going here in the anterior aspect. It's kind of sticky prostate. It's not very good. Plain. There's not very easy to progress to, but oh, there's something here. Probably the light cable was off. We're back to life. So there's some more progression here till we get to the bladder capsules, vertical bladder fibers. As we can see here, we're almost in the bladder fibers. You can see vertical fibers here. We cut through them and we get to the bladder. It's black, that's a bladder. We cut the prostate, cervical, very open. Here it is. That's it, that's the bladder mucosa, cervical mucosa, and we are in the bladder now. So now the progression is, as I do it always, I progress in a lateral to medium way. So we are like going from 3 o'clock here around, we're progressing to the 6 o'clock. So we're going to lateral, from lateral to medium. I have no proof to this, but I think this way of dissection diminishes the probability of doing some perforation when you do the ascension of the dissection here beneath the bladder neck. Here I'm connecting the two planes, inferior plane of the prostatic lobule, left lobule, and the left capsule. As you can see here, verumontanum is already attached. I'm just doing some more liberation of this left lobe. Always keeping this distance of widening. My scope is doing the setting the two structures, capsule and adenoma, in tension, not blunt dissection, and the laser is cutting through and vaporizing, or as you can see white and bubbles in the tissue that is being cut or dissected, I would say, more than cut, by this HoLEP laser. As you can see here, it's very nice. When you do it like this, there's almost no bleeding at all, and you can progress in a very controlled, very nice way. You can see every structure you're dealing with, and you can do a very nice dissection without almost no risk of considerable loss of blood, or doing a prostate capsule perforation. Same here, as I told before, I'm progressing not in a retrograde manner. I'm progressing from lateral to medial, from 3 to 6 o'clock. We see the prostate as a tube, and the semi-ovoid or spheroid shape of the prostate, as a semi or spheroid structure. We're going from the lateral to the medial aspect of the adenoma as a whole, as we are dissecting the adenoma in a whole piece, not doing any separation or fragments or lobules. Same process for the right lobe. We progress from lateral to medial, from 9 hours to 6 hours. Here you can see the prostatic arteria. As we can see here, I'm trying to make a change of plane in this right lobe, because I'm guessing the left plane, as you can see here on your screen, is kind of too deep. The capsula is getting too thin, so I'm going to keep a little bit more of capsule. So I'm going closer to the adenoma here. It's kind of attached, as I said before, kind of sticky, more on this right side than in the left side. And you can see here the capsule is very, very thin, almost going too thin to the capsule. So probably I have to go a little bit more close to adenoma to avoid any kind of perforation. that we have almost all lateral lobes dissection completed, we have only attached the whole adenoma by the verumontanum and a kind of isthmus between the verumontanum and the bladder neck at around 6 o'clock position. So now, as a final step, and after the prostatic arteries has been controlled, I do this last retrograde dissection to complete the liberation or releasing of the adenoma into the bladder. Here I start with the laser in the 6 hours position in my scope, and then when I have set a little bit of space, I change it so I can go very close to the adenoma to avoid any kind of capsule perforation and avoid extravasation of fluids or any kind of problem that can come with the capsule perforation. Even when it's not very clear that any kind of capsule perforation brings problems, it's not been proved, I would say that if there is a prostate capsule, it has to have a function, so we better than disrupt it, than touch it, than do any kind of perforation. So here is just going in the direction of bladder. You have to be very careful here. This is the area where the most of the capsular perforation are gonna happen, because here the capsule is very thin, and you go let's say going upwards in an ascending fashion, and it's very difficult. You also have this kind of leaf of capsule coming from the verumontanum, and it can be confusing because the lateral capsule, the capsule coming from the lateral lobes, is not the same, I would say, same leaf that comes from the verumontanum. So as you can see here, this like a very superficial from the verumontanum and deeper, as you can see here, coming from the lateral. So you have to be very careful what you're aiming to and what's your progression. You have to go very controlled manner, keeping in mind that you have to go to the trigono, and the direction of your progress cannot be horizontal or parallel to the ground. You have to go a little bit in the direction of the patient's belly button, if you can say that. You have to go in an upwards direction, not in a parallel direction, as you can see here. And even when you're progressing in an upwards direction, you have to keep in mind that when you lift the prostata, there's no water over here, when you lift the prostate, the capsule is also lifted. So if you go pointing a little bit downwards, you can do kind of perforation of the capsule. But if you keep that in mind, you go in a very progressive and controlled manner, there should be not a problem. I'm going from one side to the next one, from 4 to 8 in a clock, progressive manner, releasing the prostate and trying not to do any kind of perforation. Don't detach the adenoma from the capsule with a mechanic force, with a blunt dissection, always using my laser, to do it in a more controlled, more progressive and very active manner. Not leaving it, I don't leave the dissection to the way the prostate is progressing. I will say, I always say to my residents that dissection cannot be as the body of as the prostate goes opening. No, you have to do it on your own direction, choosing the best way to avoid perforation, the best way to control the bleeding, and the best way to remove the maximum amount of prostatic tissue, so the patient get a very good disobstruction, and is not gonna need any kind of extra procedure in the future, any kind of regrowing of adenoma or something like that. So as you see here, I'm approaching this adenoma from the left side, and I'm trying to leave some protection in this bladder and this prostate capsule, as it's very thin here. Besides this portion of capsule I'm trying to leave with patient, I'm trying to move the adenoma to the left and to place my scope, my endoscope, in between this let's say leaf of capsule here. As you can see, this part of capsule, to protect this, as I showed there, this very thin part of capsule about to be or to get a perforation. So this is a mucosa, bladder mucosa attached, that is getting between this progressed or already done adenoma that's completely detached. So you just have to connect these two. That's it. Always very close to the capsular fibers to avoid any adenoma and the capsule. So to not forget any kind of rest of adenoma in the prostatic fossa. That's it. You got very attached to the adenoma. That's it. You complete it here. So the left adenoma is already in the bladder. Of course, as is a block technique, it's already attached by the right side. So you have to always look what is the portion of adenoma, of portion of capsule that is attached to the adenoma, and go right through, detaching it in a progressive manner, completing your enucleation to completely release the adenoma into the bladder. When in doubt, what is supposed to be done, you have to look back like this. Take a big picture, a perspective of what you're doing, and go back to what is supposed to be done. When you're very close to the tissue, sometimes you can see what is the complete perspective. Now the adenoma is completely free, so you can see here it's a whole piece. There's this rest of adenoma here. I will cut it down, and so you can see, even when I was very cautious with the dissection, there is some parts of the capsule that are very thin, and then and then I'm showing some fat tissue even. So it's like a grade 1 perforation, not a complete free perforation. Was a grade 1. It's probably because this is was a very sticky adenoma. I'm guessing it's because of the bladder embolization, prostatic artery embolization. As you can see here, there's no bleeding. There's some very thin part of the capsular fibers. As you can see, there's almost no bleeders at all when I'm finishing this progress. So there's a vermontano, some extra hemostasia for my own tranquilidad. This won't be any kind of damage probably, or won't be any kind of bleeding problem in the next hours. And this patient will be with bladder irrigation for 1 hour, a couple of hours more of observation, and then we'll go home with a bladder catheter to be removed the next day by the nurse. So I hope you enjoyed the video. If you have any doubts or questions, you can write it here in the comments. I will try to answer any kind of comments. And if you want to read description and some data on this kind of dissection, you can always watch it in our publication. The references to our paper and DOI will be set here in the comments in this video, in the description of the video. And I hope you're going well and you keep doing enucleation. I think this is the way to go in the treatment of benign prostatic hyperplasia. Last view the prostatic fossa, and the last view of the sphincteric preserved mucosa here, completely preserved. There's no risk of stress urinary incontinence in this patient. Thank you for all.